Hello and welcome to the Dissect and Connect podcast. I'm your host, Mike Wade. This is the podcast where we explore population health issues impacting your community. Dissect and Connect is a service of New River Valley Community Services and the Montgomery County Prevention Partners. Hey gang, and welcome back to Dissect and Connect. You're listening to episode 33. I'm excited to have with me today two representatives from the American Association of Suicidology, or AAS, which happens to be the nation's largest suicide prevention membership organization. My special guests today are Dr. Jonathan Singer, President of the American Association of Suicidology, as well as the organization's Chief Executive Officer, Colleen Creighton. Dr. Singer is an Associate Professor of Social Work at Loyola University Chicago. His clinical and research interests focus on family-based interventions for suicidal and cyberbullied youth, service access and service utilization, and use of technology in education and clinical practice. He is a frequent contributor to the online community Suicide Prevention and Social Media, and is the founder and host of the award-winning podcast series, The Social Work Podcast. Ms. Creighton joined the American Association of Suicidology in June 2017. Previously, she served as Executive Director of the Alliance for Consumer Education, a nonprofit foundation dedicated to the safe and responsible use of consumer household products. Prior to her work in the nonprofit foundation arena, Colleen worked in the educational field, having taught civics at the elementary, middle, and secondary levels. She has also studied and worked abroad, having spent time in Poland, Belgium, and Germany. So, Jonathan, Colleen, welcome to the Dissect and Connect podcast.
Thanks. Great to be here, Mike.
Oh, thanks for having us.
We are truly honored to have you on the show today. And we're talking today about an issue that is uncomfortable for a lot of folks, but an important issue, and that is suicide. So you both, as I mentioned in the intro, are with the American Association of Suicidology. So, Colleen, could you start us out with a little bit of a history and overview of the organization?
Sure. So AAS is the largest membership-based suicide-related organization out there. We were founded back in 1950s, basically to look at suicide as a whole. So it started as a strong research-based organization, and since then it's grown. It includes research, but it also includes, and this makes us unique, and it's also very cool at the same time, is that it's every aspect of this issue is represented through our membership. So you have academics through research, you have clinicians that see patients, you have prevention experts, you have loss survivors, students, attempt survivors, impacted family and friends. And it's not just a random collection of individuals, but these are all through divisions in AAS. So we have these 8 different divisions that all feed in and make sure that whatever we're putting out there and whatever we're involved with has the views of all these different aspects included.
Thank you for that. Jonathan, I know that the numbers around data around suicide can be a little misleading or maybe not as accurate as we would hope that they would be. Certainly not as up to date as we would like for them to be. But I was hoping maybe you could address the prevalence of suicide in our country.
Yeah, sure thing. So suicide is the 10th leading cause of death in the United States. It's the second leading cause of death for 15 to 34-year-olds. Because of the way the data are collected, at the moment, the most recent stats we have for suicide deaths is 2018, and that's over 48,000 people died by suicide. And by the way, you can find facts and statistics, very sort of user-friendly, visually pleasing way on the suicidology.org website under facts and statistics. But it's really important to know, for folks to know that we have a huge issue with firearms and suicide. So half of all suicides in 2018, over half, were firearm-related suicide deaths. And about 3/4 of suicide deaths were males, and about 1/4 were females. And one of the reasons is that males use more lethal means, right? They're more likely to use a firearm rather than a less lethal mean.
Mm-hmm.
And even though that suicide is the second leading cause of death for 15 to 34-year-olds. Youth are not the group that have the most number of suicide deaths. And part of the reason is because youth are resilient, biologically, physically resilient, right? They can survive a suicide attempt much more easily than somebody who might be medically fragile over the age of 85, for example. And so there's some estimates that you're looking at 1,000 suicide attempts for every one death in youth, whereas you're looking at about 2 suicide attempts per one death in folks over 85. So we have a bunch of different numbers, and we can slice it a bunch of different ways. But one of the things that we've really been working hard to emphasize is that the traditional narrative about suicide statistics, which is that, you know, this is predominantly a white male problem, is misleading. Yes, you have a suicide rate of about 26 per 100,000 for white men. But if you look at Alaska Native youth, it's 60 per 100,000. And if you look at the statistics on suicidal thoughts and attempts, there was a recent study by Sean Joe and Michael Lindsay and Ariel Sheftal that found that between 1991 and 2017, the only group that showed a significant increase in suicide ideation and attempt were actually African American youth. And so it's really important for us to talk through statistics in specific contexts, because otherwise we just end up throwing out the big numbers, and that obscures some really important information about who's at risk, who may or may not be getting resources, and how we are thinking about this as an issue of diversity, both in terms of racial diversity, but also sexual and gender identity, geography, and making sure that we are having resources and services that people can experience in ways that are culturally meaningful.
Definitely a lot of variables that play into it. So, Colleen, could we talk a little bit about the commonality of stigma associated with suicide?
And I know there's a lot of debate over the word stigma too, and I think there's just confusion across the board, I think, with this topic in general. Because I think if you look, pretty much everyone in this country has been affected by the issue in some format, whether you know someone who has taken their own life, whether you've lost a family member, whether you've had your own suicidal ideation. So I think if you look at the numbers, we lose more than 48,000 individuals to suicide each year, and then you ripple that out to how many family members are impacted. The question, I think, comes in that there is no national voice speaking out on the issue. And without that, I think that's where we get the kind of confusion or fear to speak out about the issue. So, and when we talk to Congress, we say, this is great. You want your constituents to come out and talk about the issue, but are you? And so I think what we need is a little more unity at the top level across the country. People sharing their own experiences, people sharing kind of their thoughts on this. And I think that's when you're going to get more people to open up about it. But I think there is still a lot of confusion about the issue, because like we said, like Jonathan said, it's not a clear, if you don't do this, then this won't happen. It's not just kind of a XY factor. I think it's a lot more complicated. There, like you said earlier, there are a lot of variables that come into play. And I think as typically we want that simple solution. We want, okay, what's the one thing I don't have to do, or the one thing I do have to do, and check the box and we'll be safe. It requires some thought. But I think getting more people to talk about it, getting more people to share their experiences, and then kudos to you for having this conversation with us, to learn more and to be able to do a well-balanced piece to get back to your readers and your viewers about and the listeners, and kind of together get the message out that, number one, it's okay, it's nothing to be ashamed of. And number two, look across the country at how many people go through this on a daily basis.
It hits close to home for many of us. Jonathan, as a follow-up to that, can we talk a little bit about the economic impact, the impact on our society, beyond just the obvious emotional devastation that this causes?
So typically when we think of economic impact from a research standpoint, we think of years of lost productivity, right? How many years working or have we lost because of some sort of death? In the field of suicidology, that is also a complicated number. There's actually research that has suggested that, and I'm not, please know when I say this, I'm not saying this as a reason why we shouldn't work to prevent suicide, but a strict economic analysis from a few years back found that if you take into account the cost of treatment and you compare it to lost years of work, that suicide deaths might possibly save the economy money. Now, this is not a message that the authors of the study were wanting people to turn into a policy implication, nor were they saying this was that an economic analysis is the way that we need to think about suicide prevention. And so I share this because when I think about the economics of suicide, I think about families and communities. I think about the work that Katie Hardy and her friends and colleagues do with the group 6 Feet Over, where they raise money for mostly artists who are looking to cover the costs of funeral and cleanup and things like that after somebody that they know has died by suicide. Why would they have to do it? It's because we have a ton of people in this country who are not insured, who don't have the financial resources to cover catastrophic events. Why is that? Because we have an economy. We have an insurance system that ties coverage to jobs. And of course, right now we know that we have the greatest unemployment in any time since the Great Depression. And so we have a system that's fundamentally broken, an economic system that's fundamentally broken. If we look at the other side, we have maybe a middle-aged wage earner who dies by suicide. The economic impact on the family is almost incalculable, right? Because not only is there the loss of wages, but also it is all of the other expenses that come into play when you think about having to leave a neighborhood, maybe switch schools for the kids, the need for ongoing mental health services to address the loss, how that impacts college, and how that may impact future earnings for those kids. So it is an incredibly complicated economic answer, but it's absolutely one that, or the economics of it at an individual and family and community level are absolutely proof positive that we need to do everything we can to make sure people know that this world is a place that wants them to stick around.
Thank you for that. We've hinted at it a couple of times and maybe touched upon it, but I wanted to dig a little deeper into the potential impact of COVID-19 on suicide. Colleen, could you maybe start off with that, and then we'll follow up with Jonathan?
Sure, absolutely. And I think there's some new reports that came out from the CDC noting that, suicidal ideation is on the increase thanks to self-quarantine and things like that. But like Jonathan said, the big issue that we have is that we don't have any real-time data. There is no way. All of our data is 18 to 24 months old. So unfortunately, what we're afraid of is that you're not going to have a true assessment of what's happening right now until 2 years in advance. I think there's a lot of strong factors. If you look at, call volume coming into the crisis centers, for the most part, a lot of the calls are going to more like the disaster distress hotline. They're not coming exactly to crisis centers. But then, like Jonathan said, it's a very, there's all these different populations that feed into that. If you talk to Crisis Text Line, you'll see back in the beginning of quarantine and COVID, you will see, I think, that a 40% increase in the number of call volume or text volume coming in. If you look at Trevor, the Trevor Project, they had an increase, I think, when things first started happening. But where we are now, like Jonathan said, there's a lot of factors. We can see those factors. We know unemployment, economic is definitely a concern. We know that self-quarantine, sometimes you're not in a safe environment when you're in your house with your family or with your friends or where you are. So that is also another factor. But how that all comes together specifically, we're afraid, but we don't really know. And that's kind of more of the concerning part.
I want to put a fine point on one of the things that Colleen said, which is we don't have the data. And I think this is really important for everybody to know because suicide deaths are what we in the research field called a low base rate behavior. Yes, one loss from suicide is one loss too many. But when you have 350 million people and you have 49,000 deaths, that is statistically it is a hard number to make sense of. And so anytime you're looking at sort of a couple of months, then you're starting to really slice down these numbers. And what I'll say is that there are reports that Denver reported a 40% decrease in suicide deaths during the early months of the pandemic. There are also reports that Cook County, Illinois, and Fresno, California are reporting increases in suicide deaths, with Cook County at a 13% increase compared to the previous period last year, and then Fresno with 70% higher in June than the same period in June of 2019. And so it's hard to make statements about the pandemic's effect on suicide deaths because if you're talking about a 13% increase, that might be 2 deaths, depending on how many deaths there were the previous year, right? It's not like we're talking about heart attacks or some of these deaths where you're counting them in the hundreds of thousands a year, right? So if you have a jump of 40% in heart attacks, that translates into hundreds of thousands of deaths, right? And that's something that you're like, oh my God, what's going on numerically? We absolutely need to pay attention to this, and this is one of the reasons why having real-time data for suicide deaths is essential so that we can identify locations where there seems to be an increase right in the beginning so that we can respond to it, much like we are able to identify the increase in COVID cases in real time. Like, it's ridiculous that I can check a website and know how many people tested positive for COVID-19 in Louisiana yesterday, but I have to wait 2 years to find out how many people died in the United States from suicide.
And as you and I discussed a little bit before we started recording today, even then the data is often underreported.
It is often underreported because, and this is important for people to know, right? When something is identified as a suicide death, that means that a coroner or medical examiner wrote that down on the death certificate, right? That is how it is classified. And we know that when it comes to research by Matt Ray and colleagues from it's almost a decade ago at this point, what they found was that coroners without medical training were significantly less likely to classify something as a suicide death than were medically trained and appointed medical examiners, which suggests that the training that the person has and the way in which they get their job actually has an impact on what we understand to be the suicide death rate, which is, it's amazing that you can have somebody who is appointed with no medical background and that they can actually have an impact on what the death rate is in a region or even nationally.
Had never even considered that, but that is that's alarming, to be honest with you, to think about.
It is, and the flip side is, let's say that family member, one of your family members dies by suicide, and it was not something that you had any indication that they were suicidal. Maybe you haven't been in touch with them for the last couple of months, and some of the family members are like, I think it was an accident. I can't imagine that they would have been serious about wanting to kill themselves.
Mm-hmm.
And you happen to know the coroner because you play golf with him, or
Right.
you guys go to the same church, and you can be like, hey, it's unclear. Any way you can put this as an accident? He's like, sure, of course. Right now, I'm not disparaging coroners, and I'm not saying that coroners don't take their job seriously, but you get into situations where these issues of life and death take on many, many more meanings. And when you have the discrimination around suicide, and earlier when you asked Colleen about stigma, and she mentioned that was, it's kind of a tough term in the field of suicide prevention. Really, we think about it as a discrimination. People are discriminated against because of their association with either personal experience of suicidal thoughts or attempts, or their association as somebody who has lost a loved one to suicide. And my area of expertise is youth suicide and suicide in schools, and I can tell you that there's not a single parent out there who's lost a kid to suicide that hasn't thought to themselves, what did I do wrong? Right?
Sure.
They're like, what did I miss? I missed something.
Mm-hmm.
I was not a good parent. Now, this is not true, but it is a natural thing to think. And if you are a community member who, was elected to be the coroner, and you can relieve some of that burden from a family, from a family friend, I think there's a lot of pressure to do that, because the alternative is that they are then associated with something that is incredibly stigmatized, that's incredibly discriminated against in our society. And that has to change.
Absolutely. Well, you mentioned your work with young people and the focus on your research and your work around youth and schools and that kind of thing. So, given the impact of the COVID-19 pandemic, and we're all about whether or not to go back to school these days, how might that play out for this topic, or what are you concerned about most?
So a couple things that I'm concerned about is that we have evidence that kids who are involved in certain suicide prevention, school-based suicide prevention programs are less likely to attempt suicide. And these are not programs that are sort of universally rolled out, but they're in enough schools that it's likely that they are having an effect on suicide rates, suicide attempt rates at least, in those schools. None of these programs are designed to be delivered remotely. None of these programs are designed to say, hey, kid, watch a video on your own, fill out a survey, and then we're done. Because we know that's not how you do suicide prevention. There is an active component where you engage with others. And that engagement is something that we haven't figured out. How do you have a group of kids watch the same video and then process with them remotely? Right? What happens with the kid that decides to turn off their video, or their screen freezes? Right? Or they start to say something and it gets glitchy. How do you process that? We have an entire, history of the human species where we figured out ways to address communication problems in person. But we only have, 10, 15 years of limited experience trying to deal with something like teletherapy and telehealth. And so that's the downside. The upside is that as schools are rolling out remote learning, I know that I have talked with school districts about making sure that their school-based mental health staff, their school social workers and psychologists and counselors are very well versed and sort of familiar with the crisis text line, with Trevor Project, with the National Suicide Prevention Lifeline, with sort of these crisis services, as well as prepping to make sure that people know about all the telehealth services that are available. Because the upside is that maybe, it's third period and you're 15 and you're having a panic attack in math class, and that sort of prompts thoughts of suicide. Well, if you're sitting in the building, that in and of itself can be an additional stressor. But if you're in your bedroom and you can hop onto a text chat session with the crisis text line, or maybe through your insurance, you have access to a therapist that you can reach out to, that can actually in real time reduce the distress associated with suicidal thoughts. And so there's the upside, which is that if you have access and you have the resources and there's the support from schools, that there could actually be greater access to mental health services in the moment when kids are experiencing distress.
Yeah, I mean, it's a situation that's sort of been forced upon us, but I think how we adapt and respond to the situation using technology will say a lot about how we handle this moving forward.
But I also think there's a very cool, speaking of peer-to-peer, kids are coming up with some really cool initiatives too. So there's a brother and sister team in Georgia that put together, after she had some setbacks and was struggling, she was in a really dark place, and her brother helped her put together this peer-to-peer app called Not Okay. And what it does is, in the moment, if you're not feeling okay, if you need some help, you push a button and it automatically texts 5 of your closest friends and family and lets them know, hey, check in on this person. And so some of the kids are letting us know, or communication, saying what they need, which has been really cool to see.
I do recall seeing that. That's a really cool story.
Yeah, and I just want to punctuate what Colleen said. There are a bunch of apps and things that folks can use that are not related to any given school. You can also, support Not Okay by being a sort of a monthly Patreon, and we strongly encourage that because they do great work and it's by kids for kids. But there are also programs out there like the ones through Go Guardian, which detect sort of red flag suicide messages that kids are posting, or searches that they're doing when they're using school computers, right? So we know a lot of schools have Chromebooks or iPads. And so with Chromebooks or Windows-based programs, Go Guardian, if Go Guardian is in a school district, it will be able to see, this kid just searched, how do I kill myself, in Google? And then that will alert somebody, and it goes through a chain of command, which is based on whatever the district's protocols are, that people can then reach out to the kid, right? And so that's a very powerful technological solution that was in place before the pandemic that I think has a lot of promise, both for remote learning, but as we move forward.
Colleen, I want to go back to the issue around firearms. Jonathan talked about that some with the demographics around the data with suicide, but I wanted to talk a little bit more about that, dig a little deeper, and maybe just explain why the prevalence of firearms in our society is such a contributing factor to the risk for suicide. Can you just talk a little bit more about that?
Yeah, and I think very simply, it's the most fatal of all the options. And I think that's where our struggle is too, is that if you take the means, if you know someone is in distress, most likely if they attempt to take their own life with a firearm versus another means, firearms, they will instantly die. And I think there's no other second option. So for us, it's realizing that fact. It's realizing that there's other ways to address the issue. So if you know someone's in a place, there's a lot of options around there. There's some really cool mapping being done about different cities and different counties and different states have obviously different rules and restrictions on how do you get firearms out of the hands of individuals. But some of them, it's at the local gun shop. They have specific storage opportunities that they're offering someone. There's other places where local police departments, in some instances, will house it. There's places where there's just storage facilities, like gun clubs and things like that. There's some mapping coming out of, I know, like Emmy Betts and some of the others around the country in Colorado have been putting together saying, I'm in this location, and you type in your zip code or whatever, and it gives you all the options on what you can do if you or a loved one know that you need to store your firearms. So we don't get into kind of Second Amendment issues or anything like that.
Right.
Our concern is, like Jonathan said earlier, if you look at the data and you look, and so that a lot of the gun violence prevention community reached out to us and said, can we talk about the issue? And we absolutely said, can you? Because no one else is addressing the connection between firearms and suicide. And they said from, the perspective of most suicides take place with a firearm, that right there is saying, what are we going to do about it? And so that's where we get into the means safety, means restriction, what to do with the firearm. Just even know, because each firearm owner is going to have, some love gun locks, some do not like gun locks, some have now kind of just fingerprint things like that. So there's a lot of different options out there. We're not saying here's the one option, everybody has to do this. We're saying we want to work with you, but here's the situation. Let's work with you to figure out a solution. And it's going to be individualized, just like what Jonathan said with schools and youth and communities. There's not just one simple solution. I think there's a lot of variables and a lot of options. But our goal is to just make sure that we decrease the number of suicides by firearm.
Jonathan, anything else to add to that?
I would say that there is evidence to suggest that, by Mike Anestis and colleagues, they did research at a state level where they found that states that had laws that delayed access to firearms, so background checks, waiting periods, that in those states, those laws actually reduced suicide deaths. But in states where there were laws related to restricting access once people already had access to firearms, so like gun locks and storage, things like that, those did not reduce suicide by firearms. And so there's stateside data. There's also data from a couple of different countries where they found that when particularly soldiers, and I'm thinking, I think Switzerland and Israel, definitely Israel, when soldiers had their firearms kept at work and were not allowed to take them home, suicide deaths by firearms decreased significantly, and suicide deaths overall decreased. And so what we know is that legislation and policy is effective in a way that individual choice is not effective when it comes to addressing issues of firearms. And again, as Colleen said, this is not a Second Amendment issue.
Right.
I don't know anybody that's saying, well, we're absolutely going to be able to have a well-armed militia if they've killed themselves. Like, that just doesn't make any sense. Like, there's no way in which this is a Second Amendment issue. This is an issue of making sure that when people are in a crisis situation where they're thinking, everybody will be glad if I was dead, and there's no reason for me to stick around, and this is how I'm going to do it. That is not the time to expect that person to be creative and to think of multiple different reasons why they should stay. And so having these options, including ERPO, extreme risk protective orders, there are many different policy options for addressing the issue of firearms to keep people safe until they're out of this suicidal crisis, so that they can work again on finding their reasons for living.
I want to talk a little bit about survivors of loss and that population of folks who obviously live with that and probably struggle to be supported. So I just wanted to maybe get your thoughts on that particular population and maybe some ideas around how communities can support families who are affected by suicide.
You want to take this, Jonathan, first?
Well, sure. One of the things that I'll say is that Colleen mentioned that the history of the American Association of Suicidology was that, we think about it as being started by Ed Schneidman and his colleagues who were researchers. And that quickly there was the recognition that there is research with folks who have lost loved ones to suicide, right? So almost immediately there was a connection between lost survivors and research. And in the field of suicidology, we distinguish between survivors of suicide loss and suicide attempt survivors.
Mm-hmm.
And it's an important distinction. For many years, we just talked about survivors of suicide, which was somewhat problematic because you think about sort of breast cancer survivors, you're talking about the person
Right.
that had breast cancer as opposed to the person who lost somebody to breast cancer.
Right.
So when we're talking about loss survivors, we're talking about children, siblings, parents, friends, clinicians, folks who have lost people that they care about to suicide. And this is, again, one of those things where you become part of a club that you never wanted to be part of. And sometimes being in those spaces is the only time that you feel like people get you and understand you. And it's one of the reasons why the American Association of Suicidology for years has had a healing after suicide loss component to our offerings. And this year when we had it virtually, it was this phenomenal. We had a huge number of people participate in this virtual event, and it spoke to one of the things that Julie Searle, who's the past president of the American Association of Suicidology, that her research points to, that for every suicide death there are about 135 people who have been impacted by that death.
Mm-hmm.
And so one of the things that we don't have in the United States is we don't have any sort of nationally empirically validated loss support groups. We don't have, there's no sort of specific credential that one needs to have to run a loss group. And I'm not saying that they should. I'm just saying, there's a lot of things that happen in the world of loss that people might be surprised about, that you think are kind of standard, but actually don't exist in the United States. And it's a group. We have an entire division on loss survivors and at AAS, and they're incredibly passionate and powerful. And anytime you see legislation moving at the federal level around suicide, it is almost always being championed by somebody who has lost somebody
Mm-hmm.
to suicide.
So how do communities support families who have been through that? If there aren't support groups in place, and our experience in at least this neck of the woods is that is the case, what do we do as communities?
Well, let me just say that there are some online supports where if there aren't people in a community that are coming together, and today in the pandemic, that's not going to happen anyway. Mm-hmm. So being supportive online is the way. There are places where you can go online to find this support. And I think this is one of the really important things about technology, is that whether it is suicide loss or whether you are a parent of a kid who has recently been suicidal, there is a great need and a desire to connect with others who have been in your shoes.
Sure.
Right? Who have already walked along this path and are maybe a little bit further down the path, to give you hope, to give you some guidance, to be a sounding board. And as I mentioned earlier, suicide is a low base rate behavior. And so you might have an area, if you don't have a lot of people in a geographic location, you might have an area where there are only one or two people who have experienced a suicide loss in the last decade. That's not enough to have a support group, right?
Right.
But if you think online, that is a space where you can have 8 to 10 people show up on a regular basis to support each other, facilitated or not.
And I also think what we have to realize sometimes too is, especially with this topic, I don't know if it's just unique to suicide in general, but typically you think of loss survivors as just the immediate family. But you have to remember that it ripples out a little bit further. This includes the individual's colleagues at work or classmates at school, best friends, other people on a sports team or activity or hobby or something like that. So I think when you're talking loss survivor, it's not just parent, spouse, sibling, immediate family. I think we also have to kind of frame it in that it is something that affects the entire community around that individual.
And I appreciate the fact that Jonathan also mentioned clinicians, providers who have worked with those individuals. They're also affected, obviously. So,
yeah. And I just want to say that this year the Lost Survivor Award went to Ronnie Walker, who is the founder and executive director of the Alliance of Hope for Suicide Loss Survivors, which is an online 24/7 support group for folks around the world. To support the survivors of suicide loss, as well as professionals.
That's definitely a resource that I'll include a link to in our show notes today. Thank you for that.
Of course.
Colleen, I wanted to, as we wrap things up, I wanted to let you maybe talk about some of the signs to look for in a loved one that you may be concerned about.
Yeah, I defer to Jonathan really with his expertise on this too, but I think typically what you'll notice a lot of the time is just kind of withdrawing. A lot of times you'll see the person is maybe not involved in so much of their activities. There's a lot of other signs. I know some of them have been stated as giving away valuables, not really talking about, showing no hope or not really talking about the future. The problem sometimes I think we see with signs and symptoms is twofold. I think if you pull out a checklist, a lot of time with the surviving parent will look back or loved one will look back and say like, well, why didn't I see the signs? Why didn't I see the symptoms? They're right here. I just missed it. And a lot of times the signs may be not clear unless you know exactly what you're looking for. So that's my concern. Sometimes we're saying, here's a list of like 10 signs and symptoms you need to look for.
Right.
I think a lot of times it's very unique. And a lot of times, especially with the younger demographic too, the question comes up, are they just being a typical teenager? Or, is this withdrawing and kind of moodiness behavior? Is that part of just being a teenager, or is this something deeper that I should worry about? But again, I defer to Jonathan. This is really his expertise from that perspective.
So when we talk about signs and symptoms, it's really important for folks to understand that just like with heart attacks, there's a difference between risk factors and warning signs. You have risk factors for heart attacks, which include sedentary lifestyle and high cholesterol, but those are not the warning signs that somebody's having a heart attack. Right? Those would be shortness of breath, referred pain, et cetera, et cetera. And in suicide prevention, we talk about risk factors for suicide. And again, those are things that are these sort of broad categories like, white, male, middle-aged, owns a firearm. That doesn't mean that middle-aged white men who own firearms are at risk immediately to die by suicide. And so we have these warning signs. And with youth, the warning signs that we really we talk about are, have they talked about suicide? And this is, it seems like an obvious one, but you have kids who are like, oh, if I don't make an A on this test, I'm just going to kill myself. And parents and friends oftentimes say, oh, that's just a thing that kids say. It is a thing that kids say, but it doesn't mean that because some kids say it as a way of emphasizing their sense of anger or frustration, or to kind of make a point, that it means that we're off the hook. And so we check in with them about what does that actually mean for you. So making statements. We know that teenagers in general don't get enough sleep, but actually getting poor sleep increases risk for suicide. And if you have a kid that's talking about nobody would care if I lived or died, and that they have experienced, several nights of poor sleep, and these are considered warning signs for suicide, and so you need to jump on this. Warning signs meaning something is imminent, and so these are the things that are really hard for friends and family, parents, to be able to identify, because especially during the pandemic, like, we're literally around our kids all the time.
Mm-hmm.
And so we see all the fluctuations. And so it's really hard to identify contrast. It's just like when grandparents see grandkids, they're like, "Oh, you've gotten so big." And the parents are like, "Really?"
Right.
I guess they've gotten big. I just hadn't noticed because they live with me all the time. And so this is one of the reasons why it's really important that we monitor and we have other adults around. And one of the reasons why schools are so important in addressing suicide risk, because if you have an adult that's a teacher that's able to observe 25 or 30 kids in a classroom, and they have 4 or 5 classes a day, they get to see what the normal distribution is for adolescents on any given day. And that is a perspective that a parent of a single kid or maybe 2 kids just can't have.
Right. And I think we would be remiss if we didn't underscore the importance of actually having those conversations and not being afraid to ask someone if they're considering suicide, correct?
Absolutely. Yeah, there is one of the biggest myths is that if you ask somebody if they're having thoughts of suicide, that you will make them suicidal by asking that question.
Mm-hmm.
And a ton of research has demonstrated that asking the question, not only does it not make people suicidal, but if somebody has had suicidal thoughts recently, it actually can reduce their distress. Don't be afraid to ask the question, have you had thoughts of killing yourself?
Yeah.
Have you had thoughts of suicide?
Well, you've both been incredibly generous with your time, and I am truly grateful for the conversation. Before I let you go, though, I wanted to give you an opportunity to share some parting words of wisdom with our listeners. So, Colleen, I'll let you take that first, if you wouldn't mind.
Sure. No pressure at all. But I think if there's one ask, it's really to get suicide, mental health back into the national conversation. So I think we want to encourage the dialogue, like Jonathan started to say earlier, is, have the conversation with your loved ones, have the conversation with your children if you're concerned about them. But I think in general, to not be afraid to talk about mental health and to not be afraid to talk about suicide, because we're not going to make a dent or an impact in this issue until we get that national dialogue started.
Yeah, and I'll just piggyback on what Colleen just said. It is possible, it is likely that in the next 2 years we're going to have 988, which is a national mental health crisis number, much like 911.
Right.
There are some questions about funding. How are local crisis centers going to find the funds? I think this is a conversation that we need to think about when we think about how cities allocate funds for other things, and to make sure that people are being vocal and they reach out to their elected officials to say, hey, it's really important that when we look at our city budget, we think about reallocating funds towards community services, mental health services, our local crisis services, because then when 988 becomes a reality, we will have widespread, strength in numbers, community support for the kinds of services that 988 will be drawing on.
Mm-hmm.
And this is not an empirically validated statement, but this is something that I truly believe will be important in reducing suicide risk, because it will increase access in local communities to resources and services that community finds important, and that it will increase access to mental health services, which some people find important in reducing suicide risk, and that will fundamentally shift the way that we think about emergency response
mm-hmm.
to taking it away from being something where you have mental health crisis, and not all suicidal crises are mental health crises, but a mental health crisis, and you actually have mental health professionals who are the ones responding. And I think that when we think about what Colleen said about reaching out and talking to people, reach out to your elected officials right now and say, we want suicide prevention and all of the associated mental health issues to be one of your policy platforms. We want this to be something that you are stumping on when you are going around campaigning. We need to make sure that this is not an afterthought, that it's not misunderstood, that it's not brushed under the rug. Because literally, when somebody dies, it changes a life forever. When you have a kid that's having thoughts of suicide and they're wondering if this world is a place for them, it changes their life forever. And so this is absolutely something that we need to address not only at an individual and a family level, but also at a policy level.
If that's not a call to action, I don't know what is. So thank you for that. Again, Jonathan, Colleen, so appreciative of your time. It's been a pleasure, and certainly appreciate all that you both do to help inform and educate our communities about suicide and getting people the help that they need. So thank you again for the important work that you do.
Yeah, thanks for having us on, Mike. Really appreciate it.
Dissect and Connect is sponsored by Teen Connections, a leadership program through Planned Parenthood South Atlantic that empowers youth with the facts about sexual health and the skills to build stronger, healthier relationships. It's free, totally virtual, and you can earn $100 when you graduate as a Teen Connections peer educator in your community. Join a Teen Connections program from home today. For more information, be sure to check out the show notes from today's episode. We hope you've enjoyed this episode of the Dissect and Connect podcast. To learn more about Montgomery County Prevention Partners or New River Valley Community Services, be sure to check us out on Facebook or visit nrvcs.org/podcast.